So really just to say first of all that Catherine and I agonised a little bit around this in terms of how to best address this very sensitive topic. And we decided that we would split restoring sexual intimacy down what could be considered by some to be broad gender lines. But we recognise very much that in this current world that we live in, that there are people who may not recognise themselves as being belonging to one particular gender or another. So while we have split these subject areas broadly into two genders, we recognise very much that the way we're talking about sexual intimacy after cancer is very much inclusive. So that will also mean that there may be some individuals who feel that they don't identify with a particular gender and they're what we might refer to as non-binary or gender fluid. And those people are also very welcome, and we hope will take what you need and what you wish to take from both this topic and the one that we have in January, which will focus much more on people who have a penis and people who are experiencing difficulties associated with treatment that may have adversely affected sexual function from a penile function perspective. But today we're really looking at predominantly things that might have been, at least in the past, placed under the umbrella of changes that are affecting predominantly women or people who have a vagina. And these are related to changes in desire, changes in vaginal health, changes in orgasm, and changes overall in sexual well-being. And I think what's a useful place to start is just to try and put, as Catherine was saying, this aspect of our recovery and well-being and rehabilitation after cancer into context. And you can see here that this report by Macmillan Cancer Support, which was published a few years ago now, but proportionately these numbers will probably still apply even though the actual figures may differ. And what they were saying was that there's about 500,000 people each year living with cancer who face either poor health or disability after cancer treatment. And if you look at the different things that they are living with, there are people living with mental health sequelae, particularly anxiety and low mood. There are about 80,000 people living with menopausal or hormonal symptoms. There are about 90,000 living with changes in gastrointestinal function, so bowel problems predominantly, about 150,000 living with urinary problems, and then about 350,000 who are experiencing different types of sexual challenges, concerns or difficulties, which is really the main focus for our sessions today and in January. And the other thing to say really is that treatment late effects, as we often refer to some of these effects, usually emerge some months after treatment, and they can persist for in excess of 10 years. So these we're thinking here particularly of things that may begin fairly soon in the weeks and months after acute cancer treatment has ended, but may actually persist for a number of months or indeed a number of years, or may not in fact appear to be problematic until some months or maybe even over a year after your acute cancer treatment has actually ended. And that can be one of the challenges, and which obviously organisations like Penny Brown are so crucial in, is that we tend to focus so much on acute cancer care, particularly in the NHS, but we're not so good at providing medium to long-term support for people. And so when you move into stratified follow-up and self-directed follow-up, you're often in a situation where you might actually be dealing with new symptoms or new problems that have become more of a priority or more of an issue for you than they were at the time you were going through your acute cancer treatment. And yet that's at the very time when you may feel you've got less access to people who you can talk to you about it and they can support you. So if we think about what you actually need for good sex, and you look at the list there, you can see that there are many types of difficulty that can be created, if you like, by changes caused by different aspects of cancer diagnosis and cancer treatment. So we've got adverse effects on our blood vessels, our arteries and our veins, particularly our arteries, that supply different parts of our body with blood, and particularly when we are actually developing our feelings of arousal. And if those arteries aren't working properly and we're not getting adequate blood flow, that can adversely affect things like vaginal lubrication, for example, but can also mean that we don't necessarily feel as aroused in our body than we can and should do. We need nerves that work, that can send messages from our brains to different parts of our body. We need the right levels of male and or female hormones. We need to feel reasonably okay or good emotionally. And we know that people who have a cancer diagnosis and who've gone through treatment frequently experience both anxiety and low mood, and that those two particular psychological impacts of cancer do have an adverse effect on sexual well-being directly. And also we need to be with a supportive partner, whether that's a short-term partner, a casual relationship, or indeed a longer-term relationship. We need to feel that that partner can be supportive and understanding of us, and hopefully be supportive in some of the changes that we're also going through as a consequence of our illness and our treatment. Another way of looking at changes in sexual well-being can be if we actually look at this human sexual response cycle, which is adapted from work that was done in the 1960s. And although it's laid out in a sort of a linear flow, if you like, from desire through arousal to orgasm and then resolution, the reality is that many of us don't actually experience sex in that linear way. For some of us, our arousal begins, and then as our arousal actually begins, we begin to feel turned on and interested in sex. So the desire for sex doesn't necessarily have to come first. Sometimes it's more in response to the actual overtures by our partner. But irrespective of the order in which these first two phases of the human response cycle occur, the reality is that our cancer treatments can adversely affect different facets of our sexual response. And so here you can see, for example, in terms of being interested in sex and feeling that you want to respond to a partner's overtures can be adversely affected by a range of both physical and emotional changes. Things like changes in our sense of femininity, changes in our body image, our mental health can be adversely affected to varying degrees. We may feel extreme fatigue, and that means we don't have the energy to be sexual sometimes. We have changes in our hormones, either directly or indirectly manipulated by our treatments. We also have side effects of treatments, such as feeling nauseated or feeling that we've got sore mouths, or a sore vagina, or a sore rectum and anus, for example, associated with our treatment. And these can all adversely affect our receptibility and receptiveness in terms of being sexual with a partner, or indeed being sexual by ourselves. In terms of feeling turned on or aroused in relation to sex, again, you can see the different things that can occur that adversely affect this. There can be changes in nerve function or nerve injury caused by pelvic surgery, and there can be changes in our arteries and our blood flow, as I mentioned previously. The actual vagina itself can be shortened or narrowed by both surgery and by radiotherapy, and there can be a loss of vaginal lubrication, which again will cause a greater increase in friction within the vagina, which can then lead to sexual pain. And if you're experiencing changes in desire and arousability, inevitably it can make the ability to reach climax more challenging. So again, both anxiety and low mood can adversely affect the capacity to have an orgasm, as can being on medication for those changes in mental well-being. So if we're on drugs to help with anxiety, that are anxiolytics that reduce anxiety, or indeed if we're on antidepressants, some of those can both delay our ability to reach orgasm, and in some instances with some drugs can actually prevent us from reaching orgasm at all. Our orgasmic sensation may be different, again partly because of nerve and blood flow changes, but also in terms of, maybe not having the same sensation in parts of our body that are normally our erogenous zones that help contribute to orgasmic release. And then after sex, when penetrative or other aspects of sexual encounter have been completed, again, if it's vaginal penetration, we might have some bleeding or some pain after sex. We might not feel that sense of sexual release and sexual enjoyment that we're used to. And some people can feel a sense of congestion in the pelvis because the actual veins carrying the blood away from the pelvis, which has been flooded with blood during sex, are often slower to carry that blood away. And so we may feel a sort of a heaviness in the pelvis that can sometimes be unpleasant as well. So there are lots of different, another way of looking at this, apart from looking at phases of sexual response, can be looking at things like, what are the predisposing factors that make us feel less sexually well or happy in our lives? What are the things that might precipitate sexual changes? And then what things maintain sexual changes that we find challenging to overcome? So the predisposing factors are that, generally speaking, although this is not always the case, but the research certainly indicates that if we're younger at the time we develop cancer and are treated for cancer, that is usually associated with greater distress in relation to sexual disruption. There might be some cultural and religious factors that influence how we feel about sex from the very beginning, and they can be more challenging to face when we're addressing sexual changes associated with illness. We've talked about anxiety or low mood already, but other things like having a low self-esteem, not feeling very confident in our own bodies, having a negative appraisal of our body image, particularly after cancer treatment. If we have a history of either unwanted or inappropriate sexual contact or abuse in our past, that can make us more vulnerable to, again, recovering from sexual impacts associated with our cancer treatment. There might be pre-existing sexual difficulties that we've been dealing with, either in ourselves or indeed in our partners, that can also adversely affect things. And again, if we've got challenges talking with our partners about intimate topic areas such as this, that can also be difficult because we can't find the words or the way forward with our partners to actually say, look, this is something that's really worrying me. And likewise, if we've got coexisting physical or mental health conditions such as heart problems or diabetes, then again, that can adversely affect our sexual well-being in addition to what the cancer treatment may create. Most people that I've met when I've been working in psychosexual therapy and oncology come to me at the point where they've had a precipitating event, which is usually their cancer diagnosis or their treatment, and that has actually adversely affected their sexual well-being. And here we're looking at either acute treatment side effects, or we might be looking at changes in function or changes in shape in relation to parts of our bodies that we associate with intimate behaviour, such as changes in the breasts, changes in what we look like from a scar's point of view. It might be that we've changed appearance in terms of losing our hair or having hair thinning, or we may have gained or lost weight, and that has again adversely affected our body confidence. Many will have gone through a treatment-induced menopause, which adversely affects not only function, but also how we feel about ourselves. And also, don't forget, of course, the importance of the emotional impact of our diagnosis and our treatment. And likewise, we can have changes in sensation caused by either nerve damage caused by chemotherapy, or indeed nerves being altered in terms of function because of either blood flow or indeed being severed in relation to surgery. Then we've got some maintaining factors, things that make it challenging to overcome those changes. So things like thinning and changes in the vulval and vaginal tissues, that again is particularly associated with endocrine treatment. So treatments that reduce or eradicate the positive influence of estrogen in our bodies. Vaginal shortening and narrowing caused by either radiotherapy or surgery. Hot flushes and night sweats, again caused by changes in hormones such as low estrogen and reduced testosterone, because women produce testosterone from their ovaries, and there are some androgens or male hormones also produced by the adrenal glands. We've got fatigue and reduced energy, again a sense of emotional vulnerability, and sometimes difficult couple communication, and indeed unhelpful coping strategies perhaps that we've adopted, such as maybe drinking a little more than is helpful to try and help us relax, but actually that can have some adverse effects on us as well. And again, challenges that we both face in terms of being able to adapt to the sexual changes that might be impacting on us. Now, this feels overwhelming when you look at it all together. Not everybody will be experiencing all of those changes, but some of you might be experiencing some of those changes. And again, it's helpful perhaps to then think about, well, what are the changes that are most impactful on me and my partner? And what, if anything, do I want to do about that? But in order to decide what to do about that, we have to think about how we're going to start that conversation. And that in itself can, of course, be really challenging. And, you know, it's not always easy raising that topic with clinicians. As Catherine said, not all clinicians will actually raise the topic with you. Arguably, they should. It is indeed their duty of care and responsibility to do that, particularly if you've been treated for cancer, which has a high incidence of sexual disruption as part of the treatment impact. But unfortunately, in our society, talking about sex in a sensible and open way, rather than either a frivolous or challenging and perhaps not always helpful way, is not something that we've necessarily had much practice in learning. And that adversely affects some clinicians' abilities to talk about it as much as it can adversely affect patients. But I would encourage all of you to consider how you might broach this subject with somebody that you can trust within your treatment team, or indeed within your primary care team, or in relation to organisations that you link with, such as Penny Braun and others. But the key thing to start off with is being able to identify what are your current concerns, first of all to yourself, so that you can then with clarity share that with somebody else. And some people find it helpful to make a checklist of the things that are actually impacting them sexually, or to find an existing checklist online. There are a small number that you can usually access. Identify what's the top concern that you really want to discuss, and then who do you think is best placed to help you or the easiest to talk to. They may not be the same person, but the key thing is knowing, actually, I know I can speak to this person. They've always been really open. They've always said, if there's anything that I need to talk about, please contact me. So take them up on that offer. Then practice using this SEA model. This was all adapted from research that was done in the United States with women affected by breast cancer. So the first challenge is to be specific, so not to use language that's so vague that it's difficult for the person listening to actually appreciate what you're telling them. So you might start off by saying something like, I've been experiencing vaginal dryness. That's quite straightforward, it's quite direct, it's quite specific. Then explain why that concern is important to you. It's making sex uncomfortable. And then ask a question. Is there anything that you can suggest I could try to help me with this? Now, if the person you've chosen to ask doesn't have the answer for you, they've still got a duty and responsibility to actually then go somewhere else and find someone who can answer that question. So they'll either be able to answer it themselves, or indeed they might say to you, well, I'm not entirely sure myself. I know there are a number of practical solutions that can be offered, but just leave it with me and I'll get back to you. And that should be the sort of supportive response that you get if they haven't got the actual answers at their fingertips at that moment. And the key thing, I think, with everything when it comes to talking about sexual matters, which can sometimes challenge us, is practice. So you might want to actually, you know, write down what you think you're going to say to your clinician. Practice it out loud in the privacy of your own home, or, you know, practice it with your partner or with a chosen trusted friend. But just so that it actually, you can hear yourself saying those words, so that it actually feels natural and normal to you rather than something alien. Because the choice of words and the way you phrase it has to fit with your personality and who you are as a person, rather than trying to emulate any kind of ideal standard, which of course there isn't one. And then write it down if that helps, and actually take it along to your next clinic visit, because it may be that if it's difficult to raise the topic, or the way the consultation goes you feel rushed, hand it to the person and say, I didn't get the opportunity to ask this during the consultation, but it is something that's really concerning me. If there isn't time just now, I'd be really grateful if we could arrange another time either to speak on the phone or for us to meet up subsequently to talk this through. That gives you some time to prepare as well, but it also gives them some time to consider how they might actually respond to your query. There are a few sexual skills that I think can be really, really important in coping with illness. And this was work taken from a lady called Leslie Shover, who's retired now, but was a clinical psychologist working in Texas in a cancer centre called MD Anderson. Excuse me, I've got an itchy eye. There we go. And what she said was that, one of the key things is being able to have as open and honest communication as possible between partners, and the gentle use, and I emphasise gentle use of humour. Not to avoid the subject, but to try and soften the language. You know yourselves best, you know your partner best of all. So again, if humour is something that works for the two of you, then by all means use it. If it isn't, then don't necessarily introduce it, because it may not be suited to your personalities. The key is to focus very much on self-esteem and not the perfect body. Many of us, as we grow older, we change in our bodies. Our confidence waxes and wanes in terms of how we feel we look. But the reality is that we're not trying to emulate some sort of sense of false perfection. But we do want to actually feel good about ourselves and who we are, and how we express that in the context of an intimate relationship with someone that we trust and care about. There really does need to be some shared responsibility for sexual initiation. Now, that might be quite challenging for some couples, because it may be that it's been predominantly the male partner, for example, who has been the initiator of sex. But actually, they may not feel very confident initiating sex with their partner, particularly if they feel that that person's vulnerable, or that they may hurt that person and they don't want to, and they're feeling more tentative. So again, it's about how does the person who's been treated for cancer communicate what their needs and wants are, and begin to talk about that with their partner, whether it's a same-sex partnership or a opposite-sex partnership. How do we actually bring that up? How do we talk about that so that we can give our partners some ideas as to how they might approach being sexual, and that we share in that, rather than feeling that we're leaving it to our partners to first or second guess how we're feeling and what we're thinking. And we might need and want to substitute non-penetrative sexual behaviours instead of penetrative sex, because either penetrative sex isn't possible at this time, or indeed it's not something we feel ready for. We need to think about how we broaden our sexual repertoire while still respecting sexual boundaries, and see lovemaking very much as a process rather than a performance, and how we negotiate that changed process, if you like, with each other. So if we're talking to our partners about sex, here we're thinking about partners now rather than rather than thinking about clinicians. Often it helps to keep the discussions short and not sort of feel that you've got to talk for, ages and ages about something that is quite sensitive and can be quite challenging for some people. So try to keep your discussions reasonably short and manageable for each of you, so it doesn't feel too stressful. Focus on the present and on the future, what you want and what you want for the future, because you can't change the past. And so looking back to how things were before your cancer diagnosis and treatment is not always that helpful. But thinking about who you are and how you feel now, and what you both want for the future, can actually then be quite useful. Start, if you can, with less emotive aspects, if there are some. I appreciate that for some people, talking about sexual intimacy after cancer treatment can be a very emotive subject. But try to think of the less emotive elements. It might be about you wanting to reflect on the nature of your relationship more broadly, and how much you care about each other, and how you want to demonstrate that love and that care and that interest in each other. Try to check the meanings out with each other, and don't assume or try to first or second guess that you know what each other are thinking, because you may not be correct, and you may operate then on the basis of assumptions that are not accurate, and that can take you further and further away from mutual understanding rather than bringing you closer together. Try not to interrupt or hijack each other when one person is talking. Give them time and space to say what they need to say, because it may be tentative, it may be difficult to find the words, but try to have the patience to listen actively while the other person is talking, and then there'll be an opportunity for you to respond to that in due course. And try to keep it light and not too heavy if possible, as I say, using a little bit of humour if that's appropriate to your personalities. But the key thing is being compassionate to yourself and to your partner. So this is not about saying, you know, who's to blame for not being able to be sexually intimate. This is about saying this is something that might be a loss that we're experiencing, that we actually want to try and find a way forward together. But we have to do that with mutual compassion and with patience, because both of us might well be feeling quite vulnerable at this point. And if it's still too difficult to talk, think about, could I write a text to my partner instead to start the conversation, or write a short note, just to choose your words carefully and not feel under the pressure of the moment. That can sometimes be useful as well, and then be able to share that with your partner. I think the key thing too is also to be solution focused rather than problem focused. A lot of our focus in oncology, working as clinicians, is focusing on what's wrong rather than on what's going right. Here I think there's a real opportunity to try and look for solutions rather than looking for problems that are getting in the way. And that again you might need help with, rather than it just being the two of you. But couples are often very inventive actually in terms of how they can find solutions and ways forward. Explore what you like about your relationship and about being sexually intimate together. What have you always enjoyed? What have you valued? And that can be quite affirming and give you, if you like, a more confident foundation from which you can then step off and say, but what's difficult now? What do we each find challenging? They may be similar things, they may be different things. Each take a turn very gently then to explore those worries and what blocks you to being sexually intimate. And if that still feels too much, then just pick one concern each to talk about each time, and spend a little bit of time each week building on that understanding together, rather than feeling you've got to do it all in one session. Take turns to outline the concern with the other person, as I say, listening carefully to that. Breaking being sexual down into smaller steps is very much the strategy that we use within psychosexual counselling. Agreeing a beginning where both feel able to start, and then that might be something like cuddling on the sofa, it might be sharing a bath or a shower together and just being tender and caring towards each other, by washing each other's backs or whatever it happens to be. Giving each other a massage is whatever feels comfortable and manageable without overwhelming you, but being very clear that the boundaries are that you actually don't have to then progress that to anything more sexually intimate or expressive, and that is agreed in advance so that you both know where you're going to stop and to stick to them. Because one of the most common things is for people not to be sexually intimate or even touch or hug or kiss one another because they're fearful of what it might then lead on to, because naturally there would be that flow between you as a couple that you'd start by kissing, then you might start holding one another, then touching one another in different parts of your body, and before you know it you're undressing one another, you're in bed, or you're on the sofa and you're making out. But actually you might not feel ready for all of that. But if you and your partner have talked about the fact that you'd like to hold one another or touch one another, but that actually going full ahead and having intercourse is not something that you feel able to at that precise moment, if you both understand that, you can then enjoy some of these other types of intimate and affectionate touch without the fear of what it might lead on to that actually prevents you from doing anything at all. And if you still feel stuck or distressed by this, then again think, would actually talking to a counsellor help, or a sex therapist, help you in any way to actually move things forward if that's what you both want. Thinking about body confidence, this is certainly one of the areas that many women speak to me about, many men too for that matter. You might be grieving the loss of how your body was before your cancer treatment, and that takes time and support in order to actually overcome and adjust to some of those changes. What do you each value about each other? Reaffirming what it is that actually is why you're together. Re-establishing your relationship with your body. Perhaps it's changed, but doing so in the spirit of kindness and forgiveness, because your body is trying its very, very best to repair, if you like, the damage that's been caused by your cancer and by your cancer treatment. What helped you feel body confident before? Was it wearing certain things? Was it making up, making up to go out somewhere? Was it being touched and feeling that your partner was close to you and supportive of you? Was it their comments that actually made you feel really positive? Or were there other things that made you feel positive in your body, for example? And for some people, it might be about wearing something when you're being sexually intimate, where you might have previously been naked, because that's a first step, actually being able to be touched and be close to your partner by wearing very beautiful sort of underwear or lingerie of some sort, because it then feels less exposing and makes you feel less vulnerable and also more feminine and more attractive in yourself. We can talk about some of those kind of practical things that can help with body presentation. How can you reconnect with your body in the way in which your body can move? And that might be through things like exercise, through things like dance, through things like mutual massage and touch, for example. But clearly it's about things that can be tender, can be connecting, can be playful, but also be sensual rather than overtly sexual or erotic. And here I'm thinking about, just being able to touch your body in different parts of your body and just think, well, what does that touch feel like to me? And what does my skin feel like? What temperature is it? What texture is it? And when I'm touched by my partner, what do I like about that? And what is different about that? Or how do I want it to be different if it needs to be changed in some way? And then think very much about the self-care strategies that help you feel good within your body, both emotionally and physically. Things like, managing your nutrition and your diet well, looking at complementary therapies that help you feel more positive and feel more confident, massage, relaxation techniques, building the emotional resilience that Catherine was referring to at the beginning, because emotionally, if we feel very vulnerable, that certainly can adversely affect our capacity to invite someone else in close to us physically and sexually. And looking at how we present our body, albeit with how it looks and how it is different now compared to before. So these are different struggles and strategies that we can use. The struggles are there on the left-hand side. We've kind of touched on a lot of those already. We might need to change who normally initiates sex in order to accommodate changes that illness has created for us as a couple. We might need to accept that there might be a loss of what we refer to as spontaneity, but actually sex can still be really, really enjoyable if we plan when we're going to be sexually intimate and we manage that together. We need to also think about how our experience of sexual pleasure may be different now post-treatment. And one of the things that we can do is think about how we might make sex a priority. So rather than actually trying to squeeze it in briefly between, finishing work and the kids coming home from school, or fitting it in late one night after we've had a really busy day, they may not be the ideal times to do that. So think about how we might schedule some specific times to be sexually intimate or sensual together. And engage sexually with each other without necessarily waiting for spontaneous desire or arousal to be there, because it's all about building that body confidence and building those associations that can be really positive. Think about how we directly express our affection and promote intimacy between the two of us, whether that's through kissing, through touching, through hugging, through holding hands, whatever it happens to be. And really focus on low demand sensual activities that can begin that process of bodily touch and bodily connection again. We might want to use sex toys, although that might not be preference for everybody, but we can also think about using different types of lubes that can give us different sensations in our bodies. Be open to some new sexual experiences perhaps, but again being clear about what our boundaries of acceptability are for each other. So sex might well be different from pre-treatment, but not always worse. And psychosexual therapy can be really useful, particularly with changes in desire, with arousal difficulties in terms of feeling turned on to sex and experiencing difficulties with lubrication, can be helpful with sexual pain through vaginal changes and also changes in orgasm. If we're thinking about low desire and arousal, we've touched on a lot of this already, but again, I suggest sort of regular date nights, regular couple time each week, minimising interruptions and focusing on the two of you rather than the wider family or friends or work issues, which we tend to fill our conversations with. Think about having a shared responsibility for making sure that those date nights actually happen, particularly if there are differences in levels of desire between the two of you. Looking at these, as I say, low demand, sensual, erotic behaviours that don't necessarily involve penetration, particularly to begin with. And looking at negotiating what is either within or off limit behaviours. And focus on your thoughts, your emotions and your behaviours. Breaking down sexual expression into smaller, manageable steps. And then analysing, if you like, what were the things that didn't go quite so well, or the mistakes we felt we might have made with each other. And actually enhancing our understanding, if you like, by doing that. And that would often be done in conjunction perhaps with a counsellor or a therapist, particularly if you're having repeated arguments, for example. That might be something that's too difficult to address as a couple by yourselves. But this would be an approach that would be taken by a psychosexual therapist in working with you if you've got low desire and arousal difficulties. And with regard to sexual pain, which again is a very common presenting difficulty that I would work with an individual or a couple, we would look at vaginal health strategies. So we were trying to reduce or remove the pain triggers. We'd look at vaginal moisturisers, vaginal lubrication. We might look at the safety and appropriateness of vaginal estrogen. We might use devices such as vaginal dilators or vibrators to help expand the flexibility of the vaginal tissues. And I'll show you a picture of this in a moment, the use of the O-nut. We might use changes in sexual positions, for example, where the woman actually goes on top of the male partner or the other female partner to avoid deep penetration, and strategies to limit the depth of penetration in order to, again, alleviate discomfort. We might look at, again, a solo graduated exposure to things being in the vagina. If it's a long time since anything loving has been in there, or maybe we've actually had vaginal treatments that have involved putting radiation sources, for example, into the vagina, then we need to almost like reclaim that vagina for ourselves. And again, that might mean very graduated, gentle exposure to different types of vaginal sensation that can be associated with pleasurable things rather than associated with vaginal examinations and the medicalisation of that part of our body. And we might use Kegel exercises or pelvic floor physiotherapy exercises in addition to actually help with tightness in the pelvic floor muscle and in the vaginal entrance or pain associated with that. And there are pelvic floor specialist physiotherapists in quite a number of settings now that we can get referrals to through your GP or through your treatment team. And again, we would use Sensate Focus, which is a behavioural framework that we use within psychosexual counselling to help optimise how we can help your mind become aroused without being fearful of things leading on to intercourse before you're ready. So we often put a ban on intercourse so that we can actually focus on what it feels like in your mind and in your body to become turned on and aroused to sensual and sexual touch again. Some practical solutions, which again can be really useful to have some understanding of. We would often introduce non-hormonal vaginal moisturisers that are just two pictured here, Hyalofem and Yes VM, or vaginal moisturiser that stands for. And these are used 2 to 3 times a week, irrespective of sexual activity, because they're also helpful for that horrible kind of itchiness that you can get in the vulva and vagina when it's very dry and you aren't producing the same amount of vaginal moisture as before. And these can be used, they're very safe. Women who've been treated for breast cancer or who are still having endocrine treatment for breast cancer can use these types of moisturisers very safely. We can also then add in an intimate lubricant that's used at the time of being sexually active, and that's used on demand immediately before sexual activity. These can either be water, oil, or silicone based. And typically people will start by using a water-based lubricant because in a way it's the least likely to cause difficulties or cause thrush, which can sometimes be a problem with some ladies. So here we're looking at water-based maybe to start off with, but if that doesn't provide enough reduction in friction, then trying a silicone-based or an oil-based lube can be very useful. But if you are in a partnership where you're still needing to use contraception, then just be aware that some oil-based and silicone-based lubes can adversely affect the integrity of condoms. Some women will benefit from hormone replacement therapy, particularly if you've gone through an early menopause associated with your treatment. Again, that would normally be discussed with your treatment team to ensure that it's appropriate and safe from a cancer control perspective. And some women will also need to have testosterone added in, but again, that would be prescribed by the medical team and needs to be agreed in conjunction with your oncology team so that we know that it's safe in relation to your particular type of cancer. Some will use a local estrogen or topical estrogen in the vulva and vagina. Again, generally speaking, these are very safe. The only group that perhaps there is particular controversy around is the use in estrogen receptor positive breast cancer, some types of ovarian cancer, and some types of endometrial cancer. But again, through discussion with your treatment team, often we can then find a strategy where that can be safely used. But with guidance from your oncologists. We might use vaginal dilators or vibrators. Again, the use of dilators can help stretch and lengthen the vagina if it's narrowed or shortened. Likewise, vibrators can be useful because they create a sensation in that part of our body or in our clitoris, but also because they bring extra blood flow into the area, which can help with lubrication mechanisms as well as being pleasurable more generally. And then I mentioned the O-nut, and the O-nut are these silicone rings which are very soft, but can be worn on a male partner's penis or can be mounted on a sex toy if that's wanting to be inserted vaginally, and they reduce the depth of penetration and cushion the movement of the penis going into the vaginal entrance, which again can actually really help with discomfort. We obviously can also recommend going forward for pelvic floor physiotherapy or exercises to help with pelvic floor tension if that's creating problems with the vaginal entrance being tight and being painful in terms of penetration. And then although it's only available in the private sector and at the moment it's still quite controversial, some women have tried to use CO2 laser to help resurface the vaginal lining, particularly when it's become very thinned and adversely affected by the likes of endocrine treatment for breast cancer. But as I say, it's not available through the NHS, and studies are still ongoing in terms of its suitability for medium-term use in the context of women treated for breast cancer. These are just some pictures of vibrators. They come in different shapes and sizes. The top left-hand side there, the lilac graduated silicone dilators, they come through a company called Shush, which also provides a little bullet vibrator that fits into the base of them. So as well as using them to gradually dilate the vagina up, often used after radiotherapy, for example, they can also be more pleasurable and turned into something that actually feels quite nice by them not just being a dilator, but being a vibrator as well. Whereas over on the right hand side here you've got really vibrators. One, the little round one, is used on the outside for clitoral vibration and stimulation, and the one underneath again can be inserted into the vagina. Thinking now of some other resources just in the sort of last 5 minutes or so of my talk. is thinking that there are also sources of help available through different websites and podcasts, and these have become very popular in being able to talk about sexual concerns. So Shine Cancer Support, which is a charity for younger adults in their 20s, 30s and 40s, they've got podcasts and video clips on sex after cancer, dating after cancer, which can be really, really helpful. And then Liz O'Riordan, who some of you may know, who herself is a breast surgeon, but developed breast cancer and was treated for breast cancer. She has a very interesting podcast series called Don't Ignore the Elephant. And one of the first podcasts that she did was with Samantha Evans, who runs a sex product website called Joe Divine, and she and Liz talked very openly about changes in sexual well-being and how those can be overcome for both men, women and others affected by sexual changes. There are also some apps that can be really useful. This is one called the Fairly app. It's not designed specifically for people who've gone through cancer treatment, but it's a particularly useful app for women and people with a vagina who are wanting to explore how their bodies have changed and are again rebuilding their sexual confidence after cancer treatment. And they've got lots of different strategies, including mindfulness and other techniques and psychological strategies to actually help you relax and enjoy sexual touch more going forward. This is a website that was launched only in July called Sex with Cancer. It's really a combination of being able to offer very in-depth advice. It's an artwork because the people who designed this resource are artists and performance artists by background. And it's also a public campaign to raise awareness about the importance of sexual well-being after cancer. And they've partnered up with Shush, which is an erotic emporium, particularly for women, but they do sell products for both men and women. And they have now partnered with Shush. The Sex with Cancer are now in partnership with Shush, and so they also offer a sex shop and different products that are designed specifically to address particular challenges that might be prevalent after cancer treatment. So it's definitely worth a look. And they've got very good sexual experts who are sexual medicine and psychosexual therapists by background, answering questions that have been submitted by people with cancer who are living with the impact of cancer and the effects on their sexual well-being. And then this is an American website, which again is actually headed up by a professor of gynecology and obstetrics, but again, particularly for women's sexual health and for people who love and care for women. Just again, enabling you to gain more information and more understanding about the different challenges that you might face following a cancer diagnosis and treatment. If you're looking specifically for online therapy, then there are a number of resources that are available to you. Some of these you'll be able to find, particularly as COVID fades more into the background going forward, let's hope, that you can also find face-to-face therapy. But for the moment, many therapists are actually providing services online. So the College of Sexual and Relationship Therapists, which is the first website there, they've got a section on it called Find a Therapist, that you can put in your postcode and find people who are actually practicing as sex therapists in your local area. They will not necessarily be people who've worked a lot with individuals who've gone through cancer treatment, but again, if you read their profiles, you'll be able to see what they specialise in and how experienced they are. And generally, again, if it's appropriate, it may be if you're working with a therapist who maybe needs to know a little bit more about what kind of treatment impacts were created by your cancer treatment, you can put them, with your permission only, in touch with your treatment team or your specialist nurse, who could then teach them a little bit more about specifically how you have been affected by your cancer treatment and how they might then be able to support you in your sexual recovery. Relate, which is a national organisation, they have local centres in most towns and cities. And again, many Relate counsellors or couple therapists have also trained as psychosexual therapists and can help you with both couple and sexual related challenges that you may be facing. Tavistock Relationships, they also offer online psychosexual therapy and again can address concerns. The Institute of Psychosexual Medicine is more, psychosexual medicine experts working often in NHS settings. Again, you can find out where your local psychosexual medicine expert might be based in terms of where you live. And Percy Health is a relatively new self-pay organisation which is offering supportive cancer care services for people who are living with and beyond cancer. They have a variety of allied health professionals on their platform, including sex therapy, which is again delivered using a telemedicine platform. Other sources of advice and support are things like Joe's Cervical Cancer Trust, and they've got blogs and video clips, and again, a bit like today's event through Penny Braun, they also offer some recorded events specific to women who've gone through cervical cancer treatment. Breast Cancer Now also offer their helpline. They also have support groups and courses again related to different facets of living with and beyond breast cancer, including sexual intimacy and adjustment. And there's a recorded online session if you're a person living with breast cancer through Breast Cancer Haven, which I believe is still available, even though Breast Cancer Haven as an organisation sadly have had to close. I believe that there is still a website and that this might be available through that website. And then if you are in a same-sex partnership or you are part of the LGBTQI community, then there is a specific cancer support UK charity called Live Through This that are very, very supportive in terms of very specific challenges that you may face in terms of the impact of cancer on your sexual well-being and your relationships.